You're listening to Conferences on Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 28, 2023, and this is the last of our orientation series on telemedicine and allergy. Our presenters are, yours truly, Dr. J. Portnoy and Dr. Aarti Pandya. We're in the section of allergy, asthma, and immunology at Children's Mercy Hospital in Kansas City, Missouri.
All right, we're back at 11:03. We'll be moving on to our next presentation today, which will be on telemedicine. Obviously, with the pandemic, a lot of us were thrown into the world of telemedicine, telehealth. So I suspect a lot of us have some more familiarity than we have in years past, but we're going to hear a little bit more from Dr. Pandya and from Dr. Portnoy on the state of telemedicine. Thank you.
Great. Let me go ahead and share my screen. Can you see my screen?
Yes.
Right. Thank you. So this is our last presentation in our orientation series, and it's on telemedicine. The future is here. It's not something that's coming. It's something we're already using on a regular basis. These are our disclosures. None of them are relevant. These are the learning objectives. So I like to start out by just defining some terms, because you hear a lot of terms mentioned about telemedicine and things like telehealth. Telehealth is actually a more generic term. It includes the use of technology for patient care, medical education, administrative interactions. Pretty much any healthcare related interaction that occurs at a distance is called telehealth. It's a generic term. Telemedicine is a subset of telehealth. It involves the clinical management of patients in a variety of forms using technology. So if you're actually treating the patients, not just learning about them, then that's telemedicine. And then I hear this thing called virtual visits. They can substitute for in-person visits. They can be performed either using facilitated or direct-to-consumer. Personally, I don't like the term because virtual sort of implies made up, like virtual reality is made up reality rather than real reality. I think that virtual visits should be replaced by, video visits perhaps, or something like that, or distance visits, because it's not really virtual. It's real. It's just at a distance. But this is the term that you'll commonly see. And we know that telemedicine, telehealth, it has a lot of benefits. 85% of physicians say that it increases the timeliness of their care. They're able to see patients sooner. Greater than 70% are motivated to increase their telehealth because of the convenience. You can stay at home, your overhead is lower, the patients like it. You can reach more patients at a longer distance from you. Interestingly, 88% of Americans say they'd like the option of using it even after the pandemic has ended. Obviously, during the pandemic, there was no choice. You had to use telemedicine. But even after it's over, most people would like to at least have the option of using it. 75% of physicians say that it allows them to deliver high quality care. They don't feel that it is compromised. And 86% of visits, telemedicine visits, diagnosis match the in-person diagnosis. When it's been studied, you compare in-person versus telemedicine, the diagnosis and treatment pretty much are the same. So you're not really compromising anything by using telemedicine. Another advantage is cost savings, $93 per non-urgent. I mean, this is an actuarial thing. I'm sure it varies, but it is cheaper to do telemedicine rather than going to an urgent care center. The cost savings for an in-person visit is like tremendous. There's less duplication of care with virtual urgent care over in-person urgent care. You can actually see the person you saw before. The cost savings with a specialist over an in-person visit can also be huge. If they see me, there's no overhead. They don't have to come in and use a clinic and take up time and space and everything. It can also reduce unneeded emergency room visits if you do a virtual visit first in like a triage. And one study found that patients can save approximately 100 minutes of commute time, wait time, and so on by using telemedicine rather than in person. And that improves convenience and patient satisfaction. And I think we've all seen that. But do you have any thoughts about this, Dr. Pandya?
Well, I just want to give the audience some context on the work you've done. So we all are very lucky to have your expertise today, Dr. Portnoy. So for anyone who doesn't know, Dr. Portnoy has been doing both telehealth in general, but specifically telemedicine at Children's Mercy way before even the pandemic started, and has had extensive research on multiple atopic diseases with telehealth, telemedicine, and is certainly considered like an expert in this particular topic. So a lot of what I have learned, of course, has been from you, Dr. Portnoy.
But you've been doing telemedicine, so you've got experience.
I have. I just wanted to make sure everyone here had some context that you've been doing this way before even the pandemic. And one thing that, especially for an area like we live in, Kansas and Missouri, there are a lot of rural areas that are very difficult for families to actually physically get to our sites. And so having the use of a telemedicine visit, even we've published in a few of the articles that we've done together, allows expansion to rural care that in areas that otherwise, don't have these specialists readily available. So that's one other kind of benefit that we've seen for our areas too.
If you think about it, what we're doing now, COLA, is telehealth. We're learning about medicine. So we're doing it right now. Telemedicine really took off with the pandemic. Before the pandemic, there were all kinds of regulations that restricted its use. The government and the health plans were convinced that we were all going to commit fraud by doing this and not actually see patients or shortchange them or whatever and just overcharge it. So they put all of these restrictions on it to keep the patients from being seen by telemedicine. As of March 6, 2020, right at the beginning of the COVID-19 pandemic, Medicare agreed to pay for COVID-19 and other medically reasonable purposes using telemedicine. So they opened it up. They said, okay, if it's a reasonable purpose, you can use telemedicine. They also relaxed HIPAA requirements to permit providers to use their personal devices. There are some devices are more secure than others, and if you're using a service or a platform that's not HIPAA compliant officially, they allowed you to use it because there just weren't any HIPAA compliant platforms at the time. Once the emergency ended, you now have to do it again, use HIPAA compliant, but there's been time for the platforms to become HIPAA compliant. And it allows you to get COVID tests to the public more quickly. That was another thing. They waived some of the regulations about doing tests. The requirement, here's another thing that was changed. There used to be a requirement that in order to do telemedicine, you have to have an established relationship with the patient first, with a in-person visit. They waived that now. You can see new patients by telemedicine. And physicians can treat either new or established patients, and you can use telephone visits, and those are also billable now as opposed to just having to have video. And I have a lot of policy changes in this presentation. I'm not going to go through all of them. I put them in here because you can get the slides and see what the changes are. But some of them that did change was geographic location. There used to be a rule that the patient had to live a certain distance away before you were allowed to see them by telemedicine. Now I can see a patient who's next door. They don't have to be different. All healthcare providers are eligible to bill Medicare, can bill for telemedicine services. There used to be restrictions on which providers were allowed to bill for it. There were also restrictions on which services you could provide. Now the restrictions have been lifted, and pretty much any service that could be provided in person can now be provided by telemedicine. Patients can reduce or waive cost sharing, co-payments for telemedicine visits. It's really hard to collect a copay when the patient's at home and you're in your home, and how do you collect it? It's not so easy. There's also a kind of a relaxation that providers could provide services outside of their state of enrollment. That's starting to clamp back now. And some services can now be provided using telephone. It really made a difference. So these are some of the changes. Again, HIPAA flexibility, Medicaid policies, elimination of the requirements and the license requirements. I already mentioned these things. You can now prescribe controlled substances. I think they're kind of cracking back on that too. But as allergists, I can't remember the last controlled substance I prescribed, so it probably doesn't matter. And you can get paid for these other kinds of visits that I was unfamiliar with, virtual check-ins, e-visits, remote physiologic and therapeutic monitoring, all of this stuff. These are all changes that have now occurred. I'm just kind of going through these, Dr. Pandya. I apologize for that. We'll have a little more interaction in just a moment.
Of course.
These
Yeah.
are just some of the issues that have changed. Federal liability protection if you provide medical services during COVID, especially if they're related to COVID, you've got now liability protection. You're also protected from civil liability of out-of-state licensed health professionals if you provide care during COVID-19. There's also other things, equity in telemedicine. These are things that are not regulatory changes, but you do need to know where the patient is located. Are they in the same state that you are? Are they in a state where you're licensed? I always remind patients that using telemedicine is different than being in a doctor's office, because when you're in the doctor's office, these things are taken care of for you. If you're at home, you need to have a video technology and internet connection. You need to have a private space where you can talk to. You could even be in your family car. I've had patients do that. Provide information. The government now requires that you provide information so low literacy individuals can understand it. And forms and handouts need to be available in common languages spoken in the region. So these are the types of telemedicine. This is a paper that we wrote in 2020, and basically it compares in-person visits. We drive in your car from your home to your doctor's office. You can also do telephone encounters where you just talk on the phone to your provider. I've been doing that since 2001. The problem, of course, is you could not get paid for it. Now you can be paid for it. There's also direct-to-consumer where you do video visits with your patients, and that can be paid for also. And then what our hospital had to do before the relaxation of the requirements was we had to do facilitated visits. The patient would go to a clinic where there was a nurse or a respiratory therapist, somebody who could facilitate the use of the clinic's computer system to talk to the doctor. The reason you would do that is because we can set up clinics in Western Kansas that are close to where the patients are. Patient drive to that nearby clinic rather than 5 hours to Kansas City. And then I just see them through the computer, and there's digital exam equipment so we can examine them and do a real visit. Because for some reason, there's this hang up about doing a physical exam. It's like, if you can't do it, we're not going to pay you for it. It's crazy. So did you want to talk about the difference between facilitated and direct-to-consumer?
Absolutely. So there's two ways these have been termed, facilitated or non-facilitated, but essentially this is what the correct terminology is. So facilitated visit, as Dr. Portnoy mentioned, is where you have a facilitator on an end with the patient, such as seen in the picture here, who can assist with the portion of the physical exam. Perhaps if you're getting a pulmonary function test done in the clinic, they can help perform that. And then those the results of that, or even as that is ongoing, that can transmit to your office. So we're fortunate in Kansas and Missouri to have this set up where essentially, you're seeing an oral exam being performed on the patient. So that is attached to a camera, which enlarges on your computer, and you can see the oropharynx so clearly right at your office, and you're performing a physical exam that way. We have the same thing with otoscopic exams, so they look inside the ear, and you can see the entire tympanic membrane that way. And then on the skin, you can zoom in with your camera and stuff. It's very cool to do these visits. I am fortunate to have participated in doing these visits, but essentially that's the difference. So the patient is going to a location where there is a facilitator that's helping perform the physical exam or whatever other tests are being done at the time. Direct to consumer is as the name implies, the consumer, the patient, is directly talking to you without the use of an additional facilitator. So this can happen essentially where, you have a video visit with a patient where you're using either an institutional device like a laptop or your own personal device, and then the patient themselves is using their own personal device, phone, laptop, iPad, some device like that, and you both are directly talking to each other and doing a visit that way. And then, not to jump too ahead, Dr. Portnoy, and I know you're, again, way more about this, but direct to consumer, this is generally when the visit is actively occurring. There's another term called store and forward, called store and forward, where you're not having an active visit, but information is transmitted between the patient and the physician, or the provider, I should say, which is like, for instance, lab results, which are then sent back in terms of interpretation. So that's a little bit different. So direct to consumer, again, we're talking about a direct visit that's happening, which can happen either via video or audio visual.
Yeah. And of course, with the licensing requirements, the patient has to be physically in a state where you are licensed to see them.
Correct.
So
Yeah.
I always at the beginning of the visit ask, where are you located? And you tell me I'm in Kansas or Missouri, I can see them. If they say I'm in Florida, I ask them, well, think again, where are you really located? Because you want to see them, but you can't see them if they're not in a state where you're licensed. I mean, technically that's true.
Correct. Yes.
Like Dr. Pandya said, you can do a physical exam. There's a digital otoscope, and you can see the tympanic membrane. You can look in the oral pharynx. I always tell my patients they have a beautiful uvula. Look at that thing. It's hanging down. You can listen to patients. Digital stethoscopes work pretty well too. And if you have an asthma patient, you really want that. What were you saying?
No, I was saying I forgot to mention that the digital stethoscope. Let me talk about that for a second here. So on your end, you actually have something that you press where it transmits all of the sounds from the stethoscope to wherever you are, heart sounds, lung sounds, etc. So again, it's like doing a complete cardiopulmonary exam while you're sitting in whatever location you are and the patient is in a different location.
Yeah. And it helps to have like sound reduction headphones so that you can eliminate other sounds. It helps you hear more subtle sounds.
Yeah.
So this is a pretty busy slide. This is from one of the studies. This is a paper that we just got accepted in expert review. Dr. Pandya, you were the first author on this paper. And it kind of goes through the pros and cons of in-person and facilitated visit. And it's kind of what we just described. And there's also direct to consumer and telephone. Just think about a telephone visit for a minute. The patient can just be on their phone. You don't even need any special technology. Obviously, you can't do a physical exam. You can't see a rash or any of that stuff. But in many cases, that's adequate. And we used to spend a lot of time on the phone with patients, talking to them about what's wrong with them. And now we can bill for that. Whenever I have a patient who wants to talk to me on the phone, I always ask that they schedule an appointment for a telephone appointment rather than just ad hoc talking to them. The reason that I prefer that is because then I can document the visit. If you just chat on the phone real fast, a lot of times that doesn't happen, and it's more ad hoc. I'd rather have it be a regular visit. And did you want to say anything more about these kinds of visits?
One last thing I wanted to mention, I think we alluded to this a little bit, but one last advantage that you have is if one person, if you have somebody who's actively sick, like me, for instance, I have a little bit of a head cold going on right now, I'm still able to do a telehealth visit with somebody who's been waiting for months to see me, rather than having to cancel the entire appointment or have one of my colleagues come in last minute and see the patient, without putting the family at further risk of them developing an infection because they're in contact with me. And I think there was a couple of podcasts that addressed that issue as well, in the allergy immunology world, especially during the pandemic. Either families or even providers had certain medical conditions that put them at higher risk for exposure if they were to end up going in person to locations. So it's one other thing I just wanted to mention, but yeah.
Well, after all, the only infection I can get from you is a computer virus. Try not to do that. Okay, facilitated visits are mostly reimbursed the same as in-person visits. Direct-to-consumer visits are reimbursed in some states where the home is an approved site, only for established visits where the patient is. This has been waived now. Patients can be seen in their homes. Um, the direct-to-consumer is often charged as cash only and not billed to insurance if the insurance company is a problem. But really, the insurance companies are pretty good about reimbursing direct-to-consumer visits. You can do established visits. I've seen new patients by direct to consumer now. Also, it's not required that you have a previously established relationship. And the telephone encounter can now be billed. There are requirements. So let's talk about that. If I can get to the next slide. Okay. Well, actually, before we do that, you're required to get informed consent. I've never understood this. It seems kind of silly. Before you call up, you connect to a patient, they're ready to be seen. They want to start telling you about their disease, and you have to stop them and say, "Wait a minute, I have to get informed consent before we can talk by telemedicine." And then you explain what the visit that they're already doing consists of. It never made any sense to me, because if they didn't want to do it, they just wouldn't be logged in. If the fact that they're logging in, to me, seems like tacit consent. But technically, you're supposed to ask these things. To be honest, I don't ask all of these things. I usually just mention that, "Are you okay with telemedicine?" And they say fine, and then we get on with it. I don't go through all of this. You do not have to uh, get a written consent form or any of that stuff. You just have to document in your note that you got consent.
And that's from a legal perspective that Dr. Portnoy is talking about. Your institutional requirement may be different. So you kind of want to double check with whatever the institution requires.
Talk to your institutional risk managers. Interstate comments, like I've mentioned before, the provider has to be licensed to practice in the state where their patients are located. It doesn't matter where you're located. The patient has to be located in the state where you're licensed. Kind of challenges everything, because I could really just do telemedicine just as easily for anybody in any state or even internationally. It doesn't matter. And yet I'm limited because of this license thing. And so there are compacts that have basically created a driver's license model. We'll talk about that in a second. But a lot of states have enacted their own version of a license waiver, which supersedes the federal waiver, which allows a patient, if you're licensed in a state that they recognize as a valid state, then you can see it in their state too. And that some of those have now expired after COVID, so you really have to check with your own state. But there is this interstate license pact. And this is great, because if you're in one of the blue states, and there's more states coming online all of the time, you can see a patient in any other state by telemedicine. You can't see them in person, but by telemedicine, you can literally see a patient in any of the other states, as long as they're members of this interstate licensing pact. So I think that's the future eventually. If you have a license, it's the driver's license model. I'm licensed in Kansas. I can drive in Missouri. I don't need a separate driver's license in each state I drive. Eventually, we'll get to a point where the medical licenses will be the same way. Right now, telemedicine is ahead of the game there. What about malpractice? Before you see a patient, you should check with your health plan, your insurance company, not your health plan, your malpractice carrier, to see if telemedicine services are covered. They usually are, but occasionally they usually are already covered, but it may be necessary to purchase supplemental coverage if they're not. You need to confirm that it provides coverage for all locations, especially if they're seen in states other than the one the provider is licensed in using this pact. It may only cover me if they're in Kansas. And I'm seeing them in Wisconsin, Milwaukee, or Wisconsin. You wanted to assist telemedicine providers. The Secretary of State issued a letter and guidance urging state governors to enact orders at shielding healthcare professionals from certain types of liability. I don't know what happened with that now, but that was at the beginning of COVID, because everybody had to be seen by telemedicine. And it's really not intended to protect you from gross negligence or criminal misconduct, any of the bad stuff. It's really that silly stuff that we get sued over because patients get mad at us or something like that. we were protected during COVID and if we were outside of the state. Oh, okay. These are the kinds of visits that are now approved that didn't used to be approved. And I'll do one, and then maybe you could do the next one. This is telephone encounters. When we weren't allowed to do direct-to-consumer at home by telemedicine, I did a lot of telephone appointments. Just made sense. It's supposed to be patient-initiated. Usually I scheduled an appointment, and then I called them, but technically the patient's supposed to call me. It can't be an assessment. It can't be for a service that happened within the previous 7 days, and it will not lead to a service in the next 24 hours. So they don't want it to be connected to a different service that you're already in the process of providing, and it's billed by minutes. So depending on how many minutes you spend with the patient, and you have to document this, you can use these CPT codes, and there is a price list that will tell you how much you can get paid for them. Do you know anything about virtual check-ins? Have you ever done one of these?
Yeah. So the check-in can be done either with somebody from like I shouldn't say in person, somebody over the phone talking to you, or it could be done through an app essentially. So it's a short communication between a patient and a provider using various technology. Oh, and it highlights it right there. You either have synchronous discussion over a telephone or asynchronous exchange of information. And the purpose is to communicate information with their provider that could help unnecessary trips to their doctor's office. So providers need to inform patients that this is available, and there's a couple of required conditions that are listed here, including previously established relationship with the providers. Communication is not related to a medical visit within the previous 7 days, and it does not lead to a medical visit in the next 24 hours. And then those are the HCPCS codes that are listed there as well.
Yeah, I would think of this.
Oh,
This would be good if it's a patient you have and they get a rash and they want to call and ask you what's this rash, and if you're willing to receive those kinds of calls, then you can log in and look at the rash and tell it, oh, it's just poison ivy or something. Take this medicine. Saves a trip. You can still bill for it. It's the kind of thing we used to do for free when the patients would just call us and we'd spend time on the phone. Now we can bill for it. What were you going to say?
No, that's the point that I was going to make, is that I know we're talking about a lot of like regulatory things right now, but this is something that's being looked at in terms of being reimbursed from our end. So stay tuned.
Okay. When you do these things by telemedicine, by the way, you need to document the encounter as you would for an in-person office. And I always, if it's a direct to consumer, you're not going to be able to put down a physical exam, but you can put down what you were able to see on the computer, and you can bill for these things too. It becomes very complicated. Here are some documents and scenarios. This is a telehealth visit, and our hospital has these words already as dot text. They're automatic phrases that get inserted at the beginning of our telemedicine notes that say these very things. This is a telehealth visit via telephone, audio, or telephone. The patient was located at their home, and I'm located at Children's Mercy, Kansas, or something. We put that in there. Or this is a new patient visit from the patient's home via video, and I'm located. Yeah, there are things you have to put in your document in order to be able to do it. And you can also bill by time. And if you do that, you have to say when you started and when you ended and what the elapsed time was. You said that you did e-consults, didn't you?
Yes. So when I used to work at a VA, we did do e-consults. I think this service has now expanded a little bit beyond just the VA, veteran institutions or hospitals as well. But I did have some experience doing these.
Yeah, and they're really helpful to avoid inappropriate referrals because, boy, we see a lot of patients who are sent to us who really don't have any business being in the allergist's office. And this is an editorial we wrote that lists the kind of inappropriate visits that are often seen.
And essentially, what is an e-consult? It's essentially where you get a clinical question that's sent to you by a provider to your inbox. I think you highlighted on this, but I'll just kind of mention it really briefly for everybody here. So it comes to either a group, like a group inbox that one provider covers, like I'm covering the e-consults for today, so I'm covering that particular part of the inbox, or it can come directly to your inbox. And it's essentially a clinical question that somebody is asking you, and they're asking for an electronic consult. By the way, e-consult stands for electronic consult.
And these are healthcare providers asking you the questions. This is not from patients. This is from other providers who might refer patients to you.
Correct. And then you as the provider open the chart, review any relevant clinical history, any relevant imaging, any relevant lab results that have already been done, plus the clinical history that was given to you in that context of the e-consult. And then you make recommendations based on that information. An e-consult, you typically do not, then talk to the patient directly. It's typically through this particular information that, like Dr. Portnoy said, another healthcare provider has sent to you, and then you answer the question based on that. Now that can be converted, like someone can say in an e-consult, I recommend, a clinic visit for evaluation of this. But in the answering of the e-consult, you don't have to have contact with the patient in order to complete the e-consult.
Yeah, I mean, it might be my patient has acute hives. Do I need to do food testing? That could be the question they're asking. And you say, no, don't do food testing. Give them an H1 antihistamine at a higher dose and see if the hives are controlled. And then, let me know if that's a problem. I mean, you can avoid a lot of those unnecessary referrals by just giving them simple answers. Here's a study that was done at Mass General using e-consults. They do it in 47 different specialty areas, 10,000 per year. It's a lot of e-consults. The note describing the patients forward to an in-basket for review by an allergy specialist. And then the allergy specialist makes diagnosis and management recommendations in a brief note back. The referring provider then decides what to do with your recommendations. They don't have to follow them, but they can. All of them have a disclaimer because after all, you're not seeing the patient, so you're not medically liable for what happens to them. The person who sends you the e-consult is the person who is liable for the patient care. In case you're worried about liability. So there were 321 e-consults completed. Most commonly, it was for adverse drug reactions. I'm patients on amoxicillin, they got a rash now. What do I do now? Urticaria and angioedema, real common. Patients who get a lot of infections, they have immune, what do I do? And basically, about 60% of the time, an in-person visit was recommended, which is not surprising. But 26% of the time, you can provide advice and education, and then the other doctor can do that, and then you don't have to see the patient. So simple patients who really don't need a lot of care from you can be avoided. And then sometimes you're not really sure, so you recommend do these tests and then get back to me, and then we'll decide if I need to see them. That's a reasonable thing too. I think a lot of our immune deficiency patients could have that done, order immunoglobulins and flow cytometry and let me know the results, and then I'll tell you if I need to see them or not. And really, there were a lot of conditions that were done by e-consults versus in-person consults, but drug reactions was the most common reason. The advantage of this is that response time is very quick. For an e-consult, it takes an average of 21 hours. It only took the physicians 11 minutes to complete the e-consult. It takes very short time. And if the patient had waited to see you rather than getting an e-consult, it would have taken 22 days. So you see, it's so much quicker and easier to see the patient by e-consult. So they're communicated between providers only. Providers can interact with each other by phone, video, two-way communication, or just by sending electronic. That's how I think it's usually done. And it can also be used to triage patients to specialty clinics. And there are CPT codes that can be used to bill for e-consults. Not all health plans pay for it. Some hospitals have decided to give internal credit or give you RVU credits if you do e-consults, even if the health plan doesn't cover it, because it actually saves the hospital money and makes things more efficient. So there are inducements for that. What about e-visits? An e-visit is an asynchronous patient-initiated communication. You can bill for them, but it requires that you have a previously established visit. It's the usual stuff. E-visits, again, are not, I think we've already kind of talked about it. It's almost like the quick check-in, except it's a little bit more extensive visits, but it's an actual visit, but the patient initiates it, and if you have time, you can talk to them right away and do a visit. This is the most exciting stuff, though. Have you done any remote patient monitoring, Dr. Pandya?
I think I have done some with, since this is available in our realm now, I have used it with some inhaler stuff, inhaler technology. I will say the data was transmitted to the patient's, I believe, phone, and then they sent me the results from their phone. And so this is an exciting new concept that's kind of, it's been there, and it's a lot of other specialties already use it. You know, cardiology as a specialty will use this. It's essentially if you have like a Holter monitor, you know, pulmonary clinics use this as well for their own data as well. If they need to monitor, let's say, PA pressures consistently and remotely on patients. But I think it's very exciting that we have this coming up in our field more and more now too.
And basically, you need to collect data from the patients at least 16 days per month. It's billed on a 30-day basis. And there are companies springing up now that will do this for you. Now, they will provide the patient with the device, a heart monitor or pulmonary function thing or blood pressure, cough, or whatever physiologic monitor you want the patient to have. There are companies that will actually provide that to the patient and collect the data for your practice, and then they split the fees. So that's how they make their money. And it's nice to monitor because then the patient comes in to see you. You can, instead of saying, how are you doing, you actually know how they were doing because you can look at what the data that was collected. It can be very, very convenient. But now we can go one step further to therapeutic monitoring. And the difference between this and remote patient monitor, you're monitoring the patient here too, but you're monitoring them with the intent to provide therapy. So here you're also monitoring the patient, but you get real-time notifications about how the patient's doing, and that allows you to contact them right away and recommend changes in their therapy. So that's a little bit more interventional than just monitoring them. You're actually treating them. You're changing the treatment on the fly based on the results of the monitoring. So this is called remote therapeutic monitoring. And again, it's very complicated, the codes. I'm not a coding expert, so I just let the coding people do it if we start doing this. There are companies that do this also, and you might contract with one of them if you really want to get into this. So this is a paper that we just got accepted. Remember this figure, Dr. Pandya? It took forever to get it approved by the journal because there were all these copyright issues. But it's the same kind of picture that we had at the beginning. The patient and the provider can communicate with each other. They can either do it by facilitated visit. They can do it by a computer-assisted diagnosis and treatment. That's a different thing where they can have store and forward. The patient has a rash. They take a picture of it, send it to a server where you then review it and tell them what to do with the rash. Patients can also wear monitoring devices now. They can monitor their inhaler use. They can monitor their glucose or their weight if they have congestive heart failure. There's all kinds of monitors that can be attached to patients now. The data usually is collected by their phone. It's kind of an e-diary, if you will. And then the phone transmits it to a central server, and the server is accessed by the providers. There's also a medical team that might do it. As a provider, I don't want to keep checking the patient's results to see how they're doing, but medical team might do the monitoring and then notify me if something needs to be addressed, if they see something with the monitoring it. But you can see that it is becoming a lot more complicated now as we have more ways to communicate with each other. And this is just the individual patient and the medical team in managing of a patient's thing. But I think that even more comprehensive is a machine learning hub. And we talked about this with diagnostic testing. basically computers are being taught how to diagnose and treat patients. And we're going to have computers that can assist us in making the diagnosis and assist in making recommendations for treatment. But how do they learn how to do all this stuff? I mean, you have to have a training set to teach the computer the diagnosis and treatment. Basically, the computers can collect all of the data that's being monitored, the clinical trial data, research data, data from pharmaceutical companies, medical clinics. Your electronic medical record can be fed into this learning hub so that it learns what was done with different kinds of patients and what the outcome was. And it can try to optimize that over time. So it's a continuous learning model that can eventually lead to this computer-assisted diagnosis and treatment. And this is the model that I think right now is in place. And this is one of the advantages of all of these telemedicine things is, along with electronic medical records, is that they permit training of machine learning. So eventually we're going to have a colleague, you're going to have some help in your clinic making clinical decisions. Are you excited about this, or are you kind of have some trepidation, Dr. Pandya?
I think it's an exciting field. I mean, I like the field of AI, as you know, and I think there's some promising things on the horizon. So I tend to be a little bit more of an optimist when it comes to this, but I know people have different feelings about it.
Yeah, I'm not afraid that it's going to take over the world like the Cylons, but I could use, sometimes I'm in clinic and I'm not really sure what test to order or what the diagnosis is, and then I go online or whatever, but that's just the internet. Who knows how valid that is? It'd be nice to have an artificial intelligence who can give me suggestions when I ask questions about things, and can ask the right questions, and it can be intelligent and actually have accurate, up-to-date, newly learned information from real patient care. That's kind of where we're headed. I'm very excited about this. Anyway, I'm going to stop there, but did you want to talk briefly about how your experience with telemedicine has been? Do you do it, and what have you experienced?
I did it this morning, Dr. Portnoy. I have excellent experience with telemedicine. I will say that people feel differently in terms of both provider and patient perspective about telemedicine. And this can also differ in terms of whether adults are using this, whether you're using this with a pediatric patient, how technologically savvy, both parties are, et cetera. But I'm fortunate to practice with lots of families that are very comfortable with using technology, I've had such great success with telehealth. It's literally done all of the things that we highlighted in this presentation: reduced wait times to see patients, allowed me to see visits even when it's not appropriate to do an in-person visit, like today where I'm not feeling well. I was able to do a full visit with a family. And then really the big advantage, I think, is when you're reaching out to those areas where it would be otherwise a 7-8 hour drive to come see you. It's really nice to be able to offer those services to patients. So I have had a very positive experience with telehealth. And again, I have done both the facilitated and direct to consumer visits. Sorry, Dr. Miller, what were you going to say?
Oh, no, I'm just coming back on. That's all.
Oh, okay. Yeah. Yeah. So Dr. Portnoy, I have been kind of fortunate and had a positive experience with both the facilitated and direct to consumer visits. And I'm very optimistic that Store and Forward, I'm hoping, is going to follow similar reimbursements going forward, because that is a lot of time and effort that is put in from, I think every single provider here can probably attest to that, going through lab results, going through test results, and getting back to patients with their interpretation. That's essentially a version of Store and Forward. That takes a lot of...
That is reimbursed as part of e-visits, Store and Forward.
Yeah.
So you're right on.
I'm hoping that continues to be there and has appropriate reimbursement as well. And I think overall I've had a very positive experience, Dr. Portnoy. How about yourself?
Well, first of all, we never require that patients do telemedicine. It's always their choice.
Yeah.
Sometimes they have reasons why they might choose it over in-person visits. for many reasons, actually. I always ask patients how they feel about their visit. At the end of the visit, I ask, well, what do you think about video visits? I'd have to say that the vast majority of the time, the patients are very happy with it. They actually ask that the next visit also be video. They can't believe their good luck in being able to see the doctor from home and not have to drive to the doctor's office. They say, may I see you again by video? They're worried that I will have a restriction on how many video visits they get. And I assure them, you can see me however you want to see me. If you want to see me on a video, see me on a video. If you want to come in and see me in person, see me in person. You're the patient, you're the boss. I'll see you however you want to be seen. If there's a procedure, if there's some reason why they have to be seen in person, and we didn't really go into this, but there are some procedures that carry some risk, like an oral challenge, or giving an allergy shot, or things like that, that you really have to be in person. I can't give an allergy shot by video. It just doesn't work. The Italian Allergy Society actually has come up with some recommendations now that allow oral challenges to be done by video. But these are only very low risk challenges, like an early introduction of peanut in somebody who's very low risk of actually being allergic to peanut or something like that. They are starting to permit oral challenges at home by video.
There was a study about penicillin evaluation being done the same way. It was facilitated visits with a physician monitoring multiple penicillin skin tests and challenges that occurred in the same day, with a facilitator on the other end doing the skin testing. And I think the facilitator was a PA, and so it allowed for the challenges to be monitored, but then it allowed for one provider to kind of overlook, like one physician to overlook many different skin tests and challenges at the same time.
But if there's a procedure that does carry a significant risk, or at least a reasonable possibility of having a risk, those patients really should have the procedure done in a medical facility where they can be treated if an adverse reaction occurs.
Very true.
Yeah.
I think we could talk about telemedicine all day, but we'll turn it over to Dr. Miller and see if there's any questions.
We're the only thing between the audience and lunch, so we better get back to Dr. Miller. Take it away, Dr. Miller.
All right. Well, thank you again for another great presentation here. We'll open for any questions with the live audience here.
And this, other talks, any of that, please. Yeah.
I have a question. So I was wondering if you guys have found that there are some visits that work better via telemedicine, such as like maybe an initial drug allergy evaluation where you can't do the skin testing or the procedure that day, and they can avoid coming in for that initial visit.
Absolutely. That's the perfect situation, actually. The drug allergy visits, I find a high satisfaction from patients because you're not going to do skin testing on the same day. Now, we do have in our institution, sometimes if it's low risk, we don't need to do penicillin skin testing. We just need to do a direct challenge. Sometimes if there's nursing staff availability, adequate nursing staff availability, we are able to do like a challenge on the same day. But you're right, at certain, like say, for instance, you can't do that. You don't have the nursing support to do that. Absolutely. I found high satisfaction like that. So that for sure. But then there was another study actually that Dr. Portnoy published about monitoring long-term asthma in individuals through telehealth. And there's really not a difference in terms of satisfaction that the patients experienced, nor outcomes that the patients experienced with their asthma management. And so, yes, there are certain visits potentially as an initial visit. Say, for instance, another one is chronic urticaria is a perfect example. We talked about that. You're not going to do extensive testing on the patient. Most of it's going to be done through lab work. Doesn't need to be done the same day that you're there. So they can come in on their own time and get the lab work. Same thing with immune deficiency. If you literally can't get your sick child to the clinic, that's a great initial evaluation. But even for your long-term monitoring, satisfaction and outcomes, at least for asthma specifically, have been evaluated with no significant differences. So
Yeah, patients are very happy, but if they're not, they can come in for an in-person visit.
Yeah.
But you're right. There really aren't very many kinds of visits that require an in-person versus telemedicine, as long as the technology works. And I'd have to say that the main times when patients are dissatisfied with it is if there's a technical problem. The video doesn't work, we can't hear each other, connections are bad. If those things happen, patients will tend to be dissatisfied with the visit. But if the technology works, I'd say the vast majority of patients are really very happy.
And I will make one more plug-in about that. So even rhinitis, because we think with rhinitis, you're going to get aero allergen testing potentially at the first visit. So two things. One, if they can't come off of medicine like antihistamines, you can do blood testing. And again, you've saved them time and just do a remote visit with them that way. The other thing is our facility allows us to do nurse-only visits for skin tests. So even then, their time coming to the office is still saved, and they don't get double billed for 2 physician visits. They're still able to do a physician visit, or I should say a provider visit via telehealth, and then they can get a skin test done separately. So really for us, there's no restriction. And I think we can do almost anything, initially via telehealth, but it depends on what your institutional capabilities are in terms of some of these other things. So it doesn't lead to patient dissatisfaction.
Okay, any more questions out there? All right, all's quiet. Well, we appreciate everybody's attention today. Hope everybody has a great weekend, and thanks again to our speakers for wonderful presentations.